बात हो गई स्टाफ से, मैंने स्टाफ को बोल दिया है, राजकुमार से कोऑर्डिनेट कीजिए। हाँ हाँ बोलिए। हम्म हम्म हम्म, ठीक है ठीक है। हाँ हाँ, मैंने राजकुमार से बोल दिया, वो हेल्प कर देंगे।
Hmm.
बात कर ले। मुझे
Hey there, John. Good to see you again after all this time.
Good evening, Charlie.
Lovely to see you, John.
I can't hear you.
It's lovely to see you. Can you hear that? You should be able to hear me.
Your volume is not working. Can't hear you.
Microphone arranged of digital microphones,
Okay.
systems.
Okay, can you hear me now?
We can see you.
Is that okay?
Yeah. Hello, hello. Testing 1, 2, 3. 1, 2, 3.
Audible, sir. We can see you.
I'm getting some feedback.
Audio zero करो ना अपना.
Can you hear me now, John?
Yes, okay, Charlie, how you doing?
Good. I'm very good, thank you. Good to see you.
I'm gonna mute. Okay. Yeah, I'm gonna choose. I'm gonna mute you, Charlie. Nice to see you too. Yes, I can hear you, but there's background noise. Yeah, okay, everyone's muted. Someone may have YouTube open somewhere. Okay, there we go. Got it. Okay.
Hello, John.
Yes, hello.
Yeah, can you hear us? Can you see me?
I can't see you.
Sure. Start. दिखाओ. Uh, yeah, we can start करो. Start.
Hello.
Yeah.
This is Charlie in full color.
Hello, Dr. Charlie, sir.
Are
Thank you,
you in
sir.
Australia? Australia, Charlie?
So I'm in Australia. I just got back this morning, but I'm here and very comfortable. It's late at night, and I'm eager to meet all my colleagues again.
Okay. So you've been here before, this webcast, or with?
Yes, I know Uday very well. He's a lovely man, and I'm looking forward to contributing tonight or
Good.
this afternoon.
So you've been doing a lot of traveling?
A lot of traveling now, John.
Oh, okay. Are you operating still?
Yep, still operating everywhere except Australia. I've been sort of vilified in Australia and pretty well persecuted in Australia for being a little bit too high profile, I guess.
Yeah,
I'm gonna start.
yeah, it's difficult, difficult.
Hello. We are starting now.
Yeah, no, we're not starting yet.
No, yeah, it's okay. It's just hello, sir. Can you see us?
Yes, I can see you. Yeah, I can see your silhouette.
Yeah, yes, sir. Thank you. No, I'm coming on the dais.
Okay, when do you want to start?
We'll just wait for a couple of minutes.
Yeah, there's no
Uh,
hurry. And who do I introduce first? You, Dave first. I introduce you, and then you take over.
Just introduce you just introduce yourself, the Neurosurgical TV and the brain community, everybody, and then hand over. From there, I will take on. First, it's
Yeah,
you.
yeah.
It's
Then you run the show. You introduce people,
yeah.
and
Yeah.
be conscious. We have an audience out there,
Yeah.
so you have to address the camera and tell them what you're doing and stuff.
Okay.
Okay.
Just give us 5 minutes. Like we'll wait for
Yeah,
5.
no
10.
hurry. There's no hurry.
Okay.
We all
Hey, my
start. We all start late.
Dr. AK Singh has also joined. Yeah.
Mhm.
Introduce us to Neurosurgical TV. Hello.
Yeah, hi.
Can you introduce us to Neurosurgical TV?
Are you ready?
A bit, just like a prologue or something. Can you tell us
So
about what is Neurosurgical TV?
basically, we're a blog that covers neurosurgery education around the world, or a website that covers neurosurgery education around the world.
Sir, we have been listening to you since long, sir. You have been a great support all throughout the world.
Who's speaking there?
I am Dr. Abhinav. I am colleague of Dr. Uday here at Subharti Medical College.
Yeah, I have a feeling most of our audience is from India.
Yeah. So like we have been usually attending all your webcast, which you are so frequently broadcasting through this neurosurgical TV, sir.
Yes,
It's a
yes,
great support on the academic front, which you have provided to connect all the neurosurgeons on the international platforms.
yes. And we're getting bigger and stronger.
Yeah, I mean, through COVID period and I think like the past 6, 7 years, this has been revolutionizing the way neurosurgeons throughout the world are connected, are interacting with each other. And I think
Yeah,
learning from each other with
it'll
the
get
senior
better.
faculty.
It'll get better.
Yeah.
Especially
think-
when I get people to work with me, like developers, editors, that kind of thing.
Yeah, like most of the senior faculty, which is uh, which joins.
Hey, where is Suharti? What's the name of the city it's in?
So Subharti is a medical college near Delhi in Meerut, India.
Delhi?
So yes, it is just near Delhi, about 50 kilometers from Delhi,
What's the name
outskirts.
of the town? It's Meerkat?
Meerut, Meerut,
M-E?
Meerut.
Okay, Meerut.
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 Meerut. Yeah, it's old town from which we started the first Indian independence struggle in 1857. The first Indian independence struggle started from this town of Meerut, India. So it has a very
The first revolution against the
Indian
English
independence.
Empire was started from this town.
So now you're going to work on the revolution in neurosurgery.
It has to begin. I mean, yeah, like starting a new chapter in neurosurgical sciences, how to work, changing the old paradigms and
I'll
integrating with
tell
the
you, this is going to be one of the best times to be in medicine. There's going to be a
exact.
lot of changes, a lot of interesting things going on.
And those who don't leap in will regret now.
Yeah, already. Yeah, there's so much going on.
Trap? I can trap. What is it? Trap? Just as a conversation, friendly conversation. I mean, just like through the COVID eras, neurosurgical TV spread a lot. The point is, neurosurgical community is a very small community, but it has the best or the smartest minds in the world. So everybody, you get a lot of people in like general medicine, general surgery, but neurosurgery is a very like filtered type of a community. So, and gathering all the international brains, international people together on a single platform, connecting with each other. It's a very national, broad-based, good interaction. We can learn a lot, which we didn't learn during our residencies. And I think the third world, what what we are listening most probably that India as a third world country is changing now. That we'll go through this conference. I'll brief you more how we have evolved over the decades. I should say India has evolved over the decades, and why we should not be said like I'm saying it's monetary based. It's not so much the third world, but yeah, we are not as much as par with China or Germany. But yes, we are coming on the forefront, and Neurosurgical TV has done a very good job in this.
Thank you. Amongst the hospital staff, are the neurosurgeons the most technical of the other, including cardiologists, dermatologists? Are they more active in your hospital with technology?
We should start, I think, sir.
Okay, let me know when you want to start.
Start now.
Okay, here we go. 10, 9, 8, 7, 6. Oh, no, hold on. What happened? Let me see, make sure I connected to YouTube. Oh my God, I didn't even check that. Just give me a second. Yeah, I'm good. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach, home of Neurosurgical TV. We have the pleasure today of broadcasting from New Suharti Medical College in Meerut, India, the conference New Age Technology Solutions in Neurosurgery, with sessions and workshops with Brainlab. And I'd like to introduce Uday Gupta. He's more or less the director of the program, and I'd like to say hello, Uday.
Sir, nice to meet you. All of you. Good evening to all the senior faculty. Yeah, good evening to all the senior faculty. I'm Dr. Uday Gupta, and I'm happy to host you tonight along with all the senior faculty of India who has joined. And thank you. And we're starting now. So today on 30th September, we had a very small morning glitch. So, but we again managed to come back. So what today we are all about is the new surgical innovations and how these innovations can help us as an adjuvant to neurosurgery. And we'll broadly discuss about various technologies and their application and how it can help us in our skills in the present scenario. And I'll start first with introduction with Dr. Pradeep Bharti. He is the principal of Medical College, Dean Faculty, LLRM Medical College, Meerut. And he'll brief you he'll start with the talk. And good evening, sir.
Dear friends, good evening. I, on my behalf and on behalf of the Subhati Medical College and my department, would like to welcome to you this International Hybrid Conference and Workshop, Brainlab and Meerut Neurocon 2024. We have made an humble effort to incorporate the recent advances in the art and science of neurosurgery and technology. I am sure the August audience will definitely be benefited by this hybrid conference from this Subhati Medical College. Now I request the Organizing Secretary Uday Gupta to say a few words about neurosurgery in India.
Thank you. Can you start the slides? Please start the slides. Hello. Yeah, good evening, everybody, and welcome to all my international audience and my senior faculty who has joined from abroad, and the senior faculty of India who has taken time from all his busy tenures to join us. So I will just briefly tell you about the neurology, actual history of neurology research in India, and it's been an honor for me to look how neurosurgery has evolved over the decades in India. It's not a very The history is actually written by the champions, but we have to know what the history exactly is. So I'll brief you a little bit. What I found is basically on the internet. Let's start. Full screen. Slideshow. Slideshow full करा Yeah. Good evening, everybody. Next slide. So I'll start. India got its independence in 1947. So that was prior to it was the British era and British Indo era, the British era, and the few British neurosurgeons used to come and operate here. Few British neurosurgeons used to come and operate here, and it's my honor to introduce you to the bygone era of the people who started the neurosurgery in India. Next. So prior to 1947, there was no trained neurosurgeon in India. And now it's almost 70 years. So they are the initiators, Dr. A.P. Bakshar, Dr. Deshmukh, Dr. R.N. Cooper, Baliga, Narsimha, Dr. Vishwanathan Menon, and Mohan Rao, Anderson, Marijikar, and Dr. Balakrishnan Rao, Dr. Baldev Singh. So they were the very early, they planted the saplings and some of them went on to found the Neurosurgical Society of India also. the first premier society and the largest neurosurgical society of our country. Next, next, next. So after this 1940s and very early 50s and 60s, neurosurgery started to develop as an independent specialty. Previously, it was just done by a handful of general surgeons in India, and the results, as you know, was not as good. And neurosurgery has always been labeled 70, 80 years back as a very morbid branch, and that was the message was carried on everywhere. And still now it's there in some suburbs. That's not what the reality was. So in 50s and 60s, Dr. Mathai, Dr. Ginde, Dr. Chandi, Dr. Narasimha, the founders of the neurosurgical NSI, they were trained neurosurgeons from abroad, came back, some of them got trained here and started the neurosurgical work. Dr. Roy, Dr. Sinha, Dr. R.S. Bharkar, Dr. Sareen from Jaipur. So after that, you see, India has at present the largest population in the whole world. It's even crossed China now. And 60, 70 years back, again, it was one of the most populous nations in the whole world. So, and there were only handful of neurosurgeons which you can count on your fingers, 5, 6, 10 people. That was the era of 50s and 60s. Dr. P. Kanaka was the first female neurosurgeon, Dr. Pramod Bihari. And this era was 60s, 1960s. Neurosurgery as a specialty started first in 1961 in KGMC, North India. Previously, it was in South India first, even prior to it. So Dr. Tandon, Dr. Dave, Dr. Newton, Dr. Bhagwati. So these were, and in AIMS Delhi started after in 1965. The foundation of AIMS was before. But neurosurgery came in KGMC 1961 first. After that, in 62, 63, JB Pant, Dr. Raut in PGI, Dr. Arun Segal, Dr. Ginde in Bombay, Dr. S.N. Bhagwati, along with Dr. Ian Tender and Dr. Banerjee in 1965 started in AIMS. Next slide. So this was the 50s and 60s era, 1960s. Again, just 10, 50 neurosurgeons to over billions of population of the country. Next slide. So my deep and back, my deep, very humble regards to all the senior people of 60s and 70s. They are Dr. A.K. Banerjee, they are Tandon, Dr. Pandey, Dr. Dharkar, who are still both hale and hearty at 90 and are alive. And I wish them very good health. And thanks for introducing neurosurgery in India after independence. Next. So my mind thought what my teachers and everybody used to just push. The 60s and 50s era was their era. That was not my era. I mean, I was not even born then. So I went on a road to see after 70s in the last 50 years, who are the people who have championed neurosurgery in India. I thought the list is not very long and it's not too short also. It may not be exhaustive. So I'll start with you next. So as of now, I introduce Dr. Chabra. Dr. Chabra, as all of the Indians and the Southeast Asian people know, started the formation of the Chabra shunt. A shunt was also developed in Sri Chitra, but that didn't pick up much. So it again started in Lucknow, and this shunt known as the Chabra shunt is used as a very economical shunt, which is used for our population, which is not sometimes which we have to operate even for free, or sometimes which who cannot afford it. So this research was done in Lucknow, KGMC, 1960s, and it was I thought I should bring it out to you. After that, Dr. Kak, Dr. in Chandigarh, he started the establishment of neurosurgery there. Dr. Raja, when I was in Manipal, he was the prior head there. He inaugurated in KGMC Manipal, and sadly, we have lost all these three giants: Dr. Chabra, Dr. Kak, Dr. Raja. And just on the morning, I thought we also lost a pediatric neurosurgeon there in the morning. Dr. Chatterjee from Bengal. So after 1970s, these are the people who have established the footholds of neurosurgery to every small cities and every big cities of the country. Dr. A.K. Singh will be fortunate enough to have him today. He's the director, ex-professor head, neurosurgery, MAMC, NGB Pant for 40, 50 years, and he's the pioneer of so many things. We'll get to know about a short time. Dr. S.N. Mathuria, he's the ex-professor head, neurosurgery, PGIM at Chandigarh. Dr. A.P. Karapurkar, He these people may have shifted to other colleges, but this is where their legacy was written in Bombay Hospital in Mumbai. Next. Proper Depu Banerjee is an SGPJ Lucknow, more than 50 years of experience now. He has championed some of the minimal invasive surgeries, and other people also. They are doing most of the things: spine surgery, AVM surgeries, aneurysm surgeries, head trauma, spinal injuries, minimal invasive. Dr. V.S. Mehta, the Chief Sciences of AIMS, ex-chief, all his legacy is there. Dr. Pradeep Bharti in LLRM Medical College, Meerut, he was a single neurosurgeon there. A lot of these people were single at their centers who had to work for 40, 50 years alone. Dr. Sanjeev Dua, he was in PGIM as Rohtak. Professor S.K. Jain, he was the head of department in Lucknow. Next. Dr. Dev Pujari, he is in Mumbai, Bombay. Dr. Raj Shekhar, CMC Vellore, Dr. Basant Mishra, it's my honor to say his name, from Hinduja Hospital, Bombay. Very senior people, above 70 years. And after 1970s, we are the generations who owe the present status of neurosurgery to them. Dr. R.C. Mishra from SM Medical College, Agra. So I may have missed out few names, but these are the present neurosurgical giants of India. I should pay my regards to. Thank you.
Thank you, Dr. Uday, for this exhaustive list. Many might have been missed, but the fact is that many of us have struggled very difficult in different parts of the country to start neurosurgery in the various departments. It's my proud privilege to invite Professor A.K. Singh on his views of precision neurosurgery before and after neuronavigation. Professor A.K. Singh, who is presently Director of Max Institute of Neurosciences, Max Hospital, Dehradun. He is an excellent neurosurgeon and excellent human being. He was formerly Professor and Head of Neurosurgery of G.P. Pant Hospital, associated with the Maulana Azad Medical College of New Delhi. He was the first neurosurgeon to provide MVD in India, transoral decompression, and median corpectomies, and many surgeries. I would request that he may join us with his vision and he give us his blessings.
डॉक्टर ए के सिंह का PDF फाइल दिखा दो. डॉक्टर ए के सिंह का फाइल तो दिखा दो, बोला था. डॉक्टर ए के सिंह को जो आपको भेजा था वो फ्लैश कर दो. This is Dr. A.K. Singh. उनको join. Please ask him to join. Join करने को बोल दिया. This is Dr. A.K. Singh. He is presently Director of Neuroscience at Max, and he's an innovative surgeon. Please tell him personally to join. Personally, बोलो join करें.
Sir, Dr. A.K. Singh, sir, please start your screen sharing.
He was amongst the first person to start instrumentation, cervical spondylosis, artificial disc, transnasal sphenoidal tumors back in 1970s. He is presently the Association of Delhi Neurological Association and working at Max Hospital.
Please stop sharing our screen so that Dr. A.K. Singh can start.
चलेगा.
Okay, I think there is some technical glitch. I would request now Professor Charles Teo to please join us and it gives you on connectomic based glamour surgeries. Professor Teo was and remains an instrumental in the development, dissemination, acceptance of concept of keyhole minimal invasive techniques in neurosurgery. He runs a fellowship program that attracts over 600 applicants every year, and only a few handful are lucky enough to have him as a mentor. He has trained many of the world's leading neurosurgeons as distinguished centers at Barrows Neurological Institute and Johns Hopkins, Yale, and other centers. I would request him to please start his screen share.
Well, John or Uday, if you could just please reassure me that you can hear me and you can see my screen.
Yes, perfect, Charlie.
Okay, good. Well, firstly, thank you very much for the invitation to speak. Uday, if you could just please reassure me that you can hear me and you can see my screen.
Yeah, we can.
Okay, sorry, I could hear an echo, so I might turn my volume down, and by turning my volume down, hopefully I won't hear the echo. Well, first of all, to Uday and the other organisers, my deepest gratitude for asking me to speak. It's a great honour. Uday and I have been friends for many years. We attend many different conferences together, and I've been incredibly impressed by his pursuit of excellence. I've known him since he was a young man. He's much older now, and he's organising his meetings himself, and it's been good to see him blossom into a neurosurgical light in India. So this is altogether a great honour to see someone whose career I followed for many years start to shine brilliantly throughout India. I'd like to make a few comments first about Indian neurosurgery. I think you all know that I've been to India now 52 times. I consider it my second home. I've had many fellows from India. I have a very close friend and brother and colleague in Jabalpur in Madhya Pradesh. I've worked at that hospital many times. I have a lot of dear friends in India, and I cannot speak more highly of the level of excellence of neurosurgery in India. I certainly would not consider India a third world country when it comes to neurosurgery. I wouldn't even consider it a developing country when it comes to neurosurgery. I would actually consider it one of the leading countries in neurosurgery throughout the world. So please don't think that you are behind the times. You are not. You are leading the times. And many of the technological advances in neurosurgery, both conceptually and mechanically, have arisen from the great work that you're doing in India. I hope that this talk somehow sheds some light on a topic that I find a little bit embarrassing, but something that I think is very important. Embarrassing because I've spent now more than 35 years practicing neurosurgery, and unfortunately, without the knowledge that I have now, I think I've maimed and hurt and adversely affected many patients through ignorance. I don't blame myself for that ignorance. We're all very ignorant about the mapping of the human brain, why we should accept Brodmann's concept of the human brain from 1909. I have no idea, but we did. And I'm as guilty as the next person for accepting that ridiculously antiquated opinion of the brain as being divided into eloquent and non-eloquent areas. How dare we think that? How dare we think that our great maker developed a brain and put areas in the brain that were non-eloquent, in other words, served no purpose. We all accepted that very glibly, and we would do things like a frontal lobectomy, thinking that we were taking out so-called non-eloquent brain, when indeed we were taking out extremely eloquent brain. We just didn't know it. Connectomics is a evolving understanding of the human brain and mapping of the human brain, and I think we can divide neurosurgery into pre-connectomics and post-connectomics. And given that I have straddled those two eras, before and after connectomics, I think
Charlie, the slides are stuck, I think.
Oh no, I haven't moved the slides yet, John.
Oh, okay. I'm sorry. I'm sorry.
This is my introduction.
I'm not pushing you. I'm not pushing you.
It's a long introduction, but an important introduction, because I want people to understand that I think unless you adopt connectomics into your practice, you are putting your head in the sand and ignoring something very, very important. And again, I am guilty of that. When Connectomics first came out in 2016 with Glass's article, HCP article, I ignored it. I found it too difficult to apply to my clinical practice, and I ignored it. And now, on reflection, I think that was so much the wrong thing to do. This is where I hope to be in a few years' time. A visionary in Australia has shared my vision to develop a centre of neurosurgical and neuroscientific excellence. It's called the Blacktown Institute of Neurosciences. We've had permission to build it. We've got the money to build it, and hopefully the concept will turn into reality in the next few years. In the meantime, I consider myself a global neurosurgeon. I've been operating in many different countries around the world, not in Australia because of the political problems I've experienced in Australia, but certainly in the rest of the world. And I'm still enjoying a very busy practice and a very fulfilling practice. Most of my practice is glioma surgery. And as you know, with glioma surgery, it's that very, very fine balance that we all tread. And that is the balance between oncological outcome and functional outcome. There are many different ways to improve your oncological goal. We all know now that the more glioma you get out, the longer people live. It's not purely linear, but it's very close to linear. And what that means is that it is extremely important to get a good oncological outcome. In other words, a good surgical resection of the glioma. Sorry, John, I'm getting a bit of echo. So if everyone could just turn off their or mute their system while I'm talking until it's question and answer time.
Oh, I think it's gone now.
Okay, good. So how does one improve the oncological goal? Well, I'm a strong believer in adhering to basic surgical tenets. Now, I know this talk and I know this conference is about technological advances, but we can build our practice on a good foundation with technological advances. But the good foundation, I strongly believe, are basic surgical tenets. What are those basic surgical tenets? Well, the first one is the 2-point rule, the long axis of the tumor. So many times I've seen people not assess the patient's anatomy preoperatively correctly or comprehensively and attack the tumor from the wrong trajectory. You've got to look at all three axes, coronal, axial, sagittal, to determine the long axis of the tumor. Once you determine the long axis, you follow the deepest point. You can make a connection between the deepest point, the most superficial point, draw that to the surface, and that is your trajectory. That is one of the basic tenets of glioma surgery. The next basic tenet of glioma surgery is if you are going to do keyhole surgery, you don't want to clutter your small craniotomy with a whole lot of superfluous instruments. You want to maximally utilize the space. In other words, as few instruments as possible down that small hole. So the last thing you want are brain retractors. How do you avoid brain retractors? You operate in a perpendicular trajectory. If you operate in a trajectory that's not perpendicular to the ground, then the brain's going to fall into your corridor. Then you'll have to put something in there to hold it up. And all that's going to do is clutter a very small space. Here's the perfect example of someone not obeying the basic surgical tenets. So if you look at this coronal picture, it looks like a perfectly ovoid spherical tumor. So if you have a perfectly spherical tumor, there's no long axis. If there's no long axis, then you can approach it any way you like. So this person made an approach in this direction. You can see the footprints. You can see that person's craniotomy, and there's no resection of the tumor. You can see here that, again, if you looked at just the axial picture, you would think the long axis is an AP axis. But remember, if you look at all three sequences, you'll see that, in fact, the long axis is here. This is the long axis. This is going to get you the best trajectory to maximal tumor resection. And the long axis is not a medial to lateral or lateral to medial. It's not an AP. It's, in fact, this axis here seen best in the sagittal view. Not only that, you'll see that, in fact, that axis takes you through a beautiful sulcus. So this can be a superior parietal lobule, transsulcal approach to this tumor, probably only sacrificing about 2 millimeters of normal brain to get to this tumor. Then you position the patient so that you are operating perpendicular. Now, this looks incredibly awkward. There's sandbags here, the patient's twisted, but in fact, we had to do that to operate in a perfectly perpendicular fashion so that we didn't have to use self-retaining retractors. If you look at this video, again, so many times I see people wanting to do a transsulcal approach and they don't do it properly. They don't do it properly because they don't get to the bottom of the sulcus. The whole idea is to keep doing microsurgical dissection through that sulcus until you get to the bottom of the sulcus. Once you're at the bottom of the sulcus, that's when you start breaching normal brain. So we've now got to the bottom of the sulcus. We're going to use the Brainlab pointer to get us the best trajectory to the tumor. And you can see here that I've positioned the patient almost perfectly. So in other words, we are operating almost perfectly perpendicular. I'm angling it a little bit, but it's almost perfectly perpendicular, which will then give us the best technique to maximally utilize that small craniotomy. And that craniotomy is through an incision that's about 3 or 4 centimeters long and a transsulcal approach, which is about 1 centimeter in length. We've now made the track using frameless georetracted guidance, and we follow that track down using high magnification on your microscope. Again, no need for any sort of retraction because we're operating perpendicular. I'm now going to cut short the video. Once we get to the tumor, it's standard microsurgical technique, no fixed retraction, operating perpendicular, good bipolar forceps, tumors out, and there's your transsulcal approach with preservation of en passant vessels, preservation of cortical vessels, and operating through the deepest part of that sulcus. Here's a preoperative picture where this last surgeon did a very bad operation. This is a benign tumor. He took a small portion. He left the majority of the tumor there. Why? Because he didn't plan it properly. He didn't look at all 3 sequences and he didn't choose the long axis. If he had chosen the long axis, he could have got this sort of resection, a complete resection. Here's the approach, a complete resection of this benign tumor with a good surgical outcome. Okay, next, how do we improve oncological goal? We utilize the latest technology, and that's what this talk's all about. This meeting's all about. It's about maximally utilizing current technology. What is current technology? And again, I think India really leads the world in technology. When I first started teaching in India about 35, 40 years ago, I remember teaching a course where most of the Indian neurosurgeons didn't even have a microscope. But now they've adopted. I was recently operating in Karad with Cherry and Ipe. And I think it's probably the best equipped operation room I've seen in the world. Congratulations to Indian neurosurgeons for promoting excellence and promoting technology in the betterment of neurosurgery. So frameless georetracted guidance, I think, is a tool that almost all neurosurgical centers have now. Our original bipolars weren't designed for glial work or intraaxial work. They were designed for extraaxial subarachnoid space work, so they're very pointy. For glioma work, you don't need pointy bipolars, you need blunt or fat bipolars. And so you've got to have a selection of fat bipolars. Endoscope is absolutely essential if you want to do minimally invasive keyhole surgery. And if you're going to hold the endoscope with one hand, of course, you need hybrid instruments so you're not stuck being a one-handed surgeon. And these days, there's lots of companies that make hybrid instruments like these bipolar suckers. These low profile retractors are really important as well. If you have a high profile retractor, you can't angle your microscope properly. It gets in your way. You've got to make a bigger craniotomy. So again, low profile retractors, small incisions, small craniotomies, use of the endoscope and its optimization of illumination, and that will give you the best oncological goal. Intraoperative aids, well, again, a lot depends on your experience. We don't all need intraoperative aids, but if you are very early in your career and have limited experience, then it is very beneficial to use some of these aids, such as biological dyes like fluorescein and 5-ALA, intraoperative MRI, intraoperative ultrasound, confocal laser endomicroscopy. All these things are tools to help the inexperienced surgeon get a complete and radical resection of gliomas. Okay, let's talk about connectomics now. How do we improve the functional outcome of patients with gliomas? Well, it's all about knowing. It's all about knowledge. And again, I'm sorry, but I am very guilty of not adopting the knowledge that was out there in 2016 to my clinical practice, and patients suffered for it. And what I mean by that is that we all have those patients on whom we operated. We take out a glioma, they come back and they move, they talk, they can see, they don't have an optic field defect, and we're all pretty happy with ourselves. But when you do a deeper dive into those patients and ask their loved ones about the outcome of surgery, you have to believe me on this. Many of them say, well, he's just not the same person. And what they mean by that is that there's nothing really obvious, overt. There's no hemiparesis, there's no hemianopia, there's no mutism or miscomprehension, but they're not quite the same person. When you then ask the loved one, has that affected the quality of life of your husband? The answer is a clear and definite yes. Sure, they're not paralyzed. Sure, they can walk and they can drive, but they may not have the higher cognitive skills to be an effective husband, an effective father, or an effective employer or employee. So sure, they may not have an obvious hemiparesis, but they have a defect. And my excuse in the olden days was that, oh, he's had brain surgery, or it's from the radiation, or it's from the chemotherapy. I would blame everything else except my surgery. And rightfully so, because I was taught by my forefathers that I was only damaging non-eloquent brain. Oh, you can do a frontal lobectomy because it's non-eloquent. Oh, you can take off the temporal pole because it's non-eloquent. And so we would glibly take away the frontal pole, thinking that patients who came back without an overt neurological problem were good. But again, if you did a very deep, comprehensive assessment of their quality of life, you would find higher cognitive performance errors that would significantly affect their quality of life. How do we know about that? Because we now have the Human Connectome Project as part of our armamentarium. And you've therefore got to identify those so-called non-eloquent parts of the brain and preserve them as best you can, just like you used to preserve the motor area or the language area or the visual area. So it's all about preoperative gathering of information and then intraoperative utilization of that information. And you've got to map what you can map. And if that means awake surgery, fine. If that means a sleep surgery, fine. But whatever you do, you've got to try and map and preserve those very eloquent parts of the brain. This is Brodmann's map, 47 areas. And all those areas in between, they were considered non-eloquent because we never really identified what they did. How would we find the motor strip? Oh my God, it was so primitive. We used to get a tape measure and tape the point, the midpoint of the nasion inion. We'd then go 2 centimeters behind that midpoint. We'd draw a line down to the Sylvian fissure, and that was our motor strip. It was a very primitive way of ascertaining eloquent brain. It was on the presumption that all brains are the same, And it was on the presumption that all brains morphologically were the same. That has now been proven to be absolutely wrong. I think the great work of Nada Sanai and those at Mitch Berger from UCSF showed us that of all those thousands of awake patients they did, they realized that in fact speech wasn't always in Broca's area. Comprehension wasn't always in Wernicke's area. In fact, 5% of people, their motor speech is not in their inferior frontal gyrus. It's not in their middle frontal gyrus. It's in their superior frontal gyrus. That's how variable everyone's brain is. So to get this, to map someone's brain based on a presumption that their motor area is here or their speech area is there is so wrong. But we all did it. We all did it, and our patients suffered the consequences. Okay, but now there's no more excuses. We have now become more sophisticated in our preoperative mapping of the brain, and that is the HCP, the Human Connectome Project. The Human Connectome Project was published in Nature in 2016 by Glasser et al. And it was the formulation and distillation of 2009, 7 years of research, millions of dollars, thousands of subjects, gathering of data to try and map the human brain to show us that, in fact, this was wrong, but this was right. No more can we consider the brain 47 Brodmann areas. We now have to consider the brain as over 370 different areas. And these areas form networks. So there's no such thing as non-eloquent brain. We call these areas parcels, and all these parcels are connected by white matter bundles. Networks are parcels that are wired together and fired together. And now to try and help you memorize these parcels, we break the brain up into major and minor networks. The higher order networks are the networks that you may not have heard about, and the lower order networks are those networks that are anthropologically very primitive, and I'm sure you've heard of them. The language area, sensory motor area, visual area, limbic area, these are very older order networks. The more recent order networks are the salience network, central executive network, default mode network, DAN or dorsal attention network, VAN or ventral attention network. I never quite understood what a network is or was until someone showed me this analogy. Think of a function like imagination or speech or moving one's left toe as a beautiful music produced by an orchestra. A parcel is a single person in that orchestra. A network is a section of that orchestra. Salience network is the conductor of that orchestra. So that means that, in fact, to produce a function, it doesn't always just take a single network. Many different parcels from many different networks can still be wired together and function together and fired together to create a function. Are the higher cognitive functions important? I mean, this talk is all about adopting connectomics to your clinical practice. Well, so what? I mean, do we really need to do that? What if we do affect someone's ability to relate to their children? What if we affect someone's sexual performance? What if we affect someone's executive functioning or working memory? Is it really going to make that much difference? Well, the answer is yes. There is literature out there that's already showing that someone with a higher cognitive network problem can have just as much an impact, a negative impact on their quality of life as someone with a hemiplegia or someone with mutism. It really does negatively impact someone's quality of life and therefore their longevity as well. So just like creating a hemiplegia negates the effect of a resection because they still die early because you've given them a deficit, so too, if you damage their high cognitive networks, you'll also get reduction in their longevity and certainly reduction in their quality of life. So it is very important to maintain not only the lower order networks, but also the higher order networks. Assessing someone's higher order networks is not easy. I used to think that, KPS was fine. They come back and you do a Karnofsky performance score. Or, sometimes to be really sophisticated, you get them to see a neuropsychologist to do a battery of neurocognition tests. Even 6 hours of neurocognitive assessment doesn't always pick up a higher order network neurological problem. It's something that's sometimes incredibly subtle. Those tests, no matter how many questions are asked, aren't going to pick up the fact that the patient may or may not be able to have pleasure having during sex, or may not pick up that they can relate to their children, or that they have motivation to get up and do things on the weekend. They're very subtle things that are very important, but often not picked up by our rudimentary neurological examinations and even our sophisticated questionnaires that neuropsychologists ask. Can awake surgery identify and avoid damage to these neurocognitive networks? Now, this is a very, very controversial question because it evokes a lot of emotional response. Why? Because there are advocates out there that say that you must do awake surgery whenever you do hemispheric glioma surgery because it is imperative to map all these different areas. Okay, then there's another school of thought that says, well, hang on, these high cognitive functions that you're meant to be mapping are so sophisticated. Really? Can you test these things when a patient's sitting under a drape with their brain opened up, who had a little bit of sedation, who've been lying on an uncomfortable table for 6 hours? Do you really think you're going to be able to pick up how they relate to their children, for example? And so there are these two schools of thought. One school of thought says wake surgery it's kind of useless because you're not going to be able to pick up all these very important functions. And the other school of thought that says, well, you've got to do awake surgery or you won't be able to pick up anything. I've tried to answer the question. I still don't quite know, but I do know one thing. And even awake surgeons will make this claim. No, hang on. Now, let me get it right. Let me get it right. Bad awake surgery is worse than no awake surgery or a sleep surgery. So in other words, if you're going to do it, you've got to do it well. You've got to have the personnel. In other words, you need a neuropsychologist in the room. You need a neurologist. You need a good neurophysiologist. You need someone who speaks their primary language. They need to be fully awake. You need to be doing all those cognitive tests. You need a neuropsychologist in the room. Unless you have that team and unless you do it properly, it's probably not worth doing. So it's very cost consuming, it's very time consuming, and not everyone has the resources to do that. So if you're not going to do it properly, you probably shouldn't do it at all. So in theory, yes, but in practical terms, no. Patients need to be extremely alert and cooperative, and oftentimes they're not because they've been given a bit of sedation and it's taking a long time. It introduces this huge issue of cost because you need all that manpower in the room. And of course, it prolongs the whole operation by a significant amount, hours and hours and hours. So even the experts report varying results and question the reliability of awake surgery. And I'm talking the experts, the people who've done thousands of cases. And here's one of them. The late George Samandouros, bless his soul. He was a good man who only died in July of this year at the tender age of 60. And all credit should go to George for really promoting glioma surgery in the next century. In other words, the post-connectomic glioma surgery. He was a great advocate of awake surgery, but even this man, whose career was all about awake surgery, even he said in this article, high order flexible cognitive functions are subserved by very widespread, large-scale, interacting, synchronized networks, and a brief, temporary disconnection may not access specific cognitive subdomains, or indeed may disconnect interacting networks. Therefore, excessive claims should be tempered. In other words, it's so complex, it's so complicated, it's all very, very complex about all the different networks that are joining together to create this function, maybe that short period of stimulation doesn't quite get it right. And in honor of George, this is a picture, one of his courses in London with Hugus Defoe, Mitch Berger, Walter Stummer. And so this is a person who really did advocate awake surgery, yet he was brave enough and courageous enough to say, listen, I'm an advocate of awake surgery, but it may be not giving us the information that we need. And even Guillaume Hubet, who is the neurologist who works with Dufault, even he has questioned the validity of awake surgery. And I'm running out of time, so I won't go into it, but he goes through this article saying that it's too complex, it's too individualized, and maybe we are basically being a reductionist by using awake surgery. So I used to do glioma surgery ignorant of the Human Connectome project. I used preoperative MRI, I occasionally used DTI, I consulted the patient informing the risks of damage to motor, speech and vision, but I did not talk about depression, anxiety, relationships with their children, etc., etc. I did no intraoperative mapping. I did no awake surgery. I often did supramarginal resections whenever I thought it was possible, in other words, in non-eloquent areas. And then when they came back to my clinic, I used very rudimentary post-operative neurological examinations and the Karnofsky outcome score. I didn't do neuropsych evaluations. Here's a perfect example of ignorance on my behalf. This is a young boy who had a glioma that was growing in the right frontal area. Again, what did I tell the parents? Oh, look, it's the right frontal area. It's the most non-eloquent part of the brain. The risk of surgery is very low. I should be able to do not only a resection, but a bit of a supramarginal resection, and he should have no adverse outcome. I did all the correct mapping. I showed all the networks around it. I did the intraoperative mapping. I did a minimally invasive keyhole approach. I did a fantastic resection, got all the tumor out. And again, I boasted about how good he looked after the operation. Here's the patient coming back. He was not hemiplegic. He was very grossly neurologically intact. But look at this. Look at his clinic note years later. It was a pleasure to see Mannix and his parents in clinic today. You know his story well, so I'll be brief. He has psychosocial and emotional problems that have been evident for the last 4 years and likely started at the time of my surgery. These deficits include poor working memory, inability to plan motor functions, poor social interaction, speech problems, poor concentration, anxiety. In other words, what did I do? Clearly, I affected his central executive network. I didn't even know it. I didn't know it because I didn't know the information at the time. The Human Connectome project wasn't out at that time. And I didn't know that I was affecting high cognitive parts of his brain. I didn't even know what the central executive network was in those days. Here's another case. Young lady, frontal ganglioglioma. Of course, I'm going to do a supramarginal resection. I want to get a good oncological outcome. So I'm going to take the tumor out. I'm going to take a bit of normal brain, and I'm going to try and keep her alive for as long as possible. There's a resection, fantastic resection, and to this day, that tumor has not come back again. So from an oncological viewpoint, it could not have been a better operation. But look at the functional outcome. This is her first clinic note. She spent the entire consultation complaining and not once focusing on the positive aspects of her condition. You can see I was getting a little bit annoyed with her. She's had so many complaints. She's had no recurrence of her brain tumor, and her latest MRI scan looks excellent. She just had a list of over 40 complaints she had to voice to me over the 40-minute consultation. I was obviously irate. I obviously couldn't explain it, and I thought she was just a bit crazy. That was in 2009. In 2021, okay, it was my pleasure to see this lady in my office today. She continues to do very well from a brain tumor viewpoint, but very poorly from a depression, memory disturbance point of view. She continues to complain of poor memory, anxiety, depression. These symptoms of beta line. So if you summarize her functional outcome, no working memory, change in personality, depression, anxiety, can no longer multitask, and an inability to process social situations, I damaged her DMN and CN. I didn't even know it. I thought she was a bit crazy. But in fact, my surgery created that incredibly negative functional outcome in that person. So with that in mind, and now that I can use the information from the Human Connectome Project, I've completely changed the way I do glioma surgery. I now use the HCP and I incorporate the higher cognitive networks as just important as a motor network or a speech network. The central executive network, the default mode network, and the salience networks are just as important to outcome and quality of life as the sensory motor, the limbic, the visual, the speech. And this is just an example of that. Okay, we all know the sensory motor network. This is a FC scan showing the parcels and the white matter connected to the sensory motor cortex or the sensory motor network. But did we know about the central executive network? Look at the parcels of the CEN. The parcels of CEN very much in the right frontal lobe, that so-called non-eloquent part of the brain. Look at the neck connections with the cingulum back to the parietal area and the temporal area. These are all parts of the central executive network. Look at the default mode network. Again, frontal pole has parcels of the of the DMN. So any sort of polectomy, whether it's dominant or non-dominant side, could affect your default mode network and affect your cognition, higher cognition. And salience network is the insular, parietal, occipital, temporal, all these parts, all these parcels are part of the salience network. So here's a glioma now. Now it's nowhere near the motor area, but again, it may not be near the motor area, but let's look at the higher cognitive networks. It's very close to the VAN, the ventral attention network. And you can see that any sort of lateral approach here, I could have potentially damaged the VAN. So sure, safe from the motor, but not safe from the VAN. So the whole idea was to take this tumor out and preserve VAN, which we did very nicely with a good outcome. Here's another patient with an oligodendroglioma and a plastic of the insular region and the overlying opercula. I'm not quite sure where tumor starts and tumor finishes. If you look at it really closely, up here, for example, is that tumor there? Is that edema? It doesn't really matter because once I map it, I can tell whether any functional parcels are in that area. And again, look at the map here on the coronal view. What's this? Is that tumor just like this, or is this edema? So again, the more information I can give myself, the more I can get a functional good outcome as well as a good oncological outcome. So I use all the information, I look at all the parcels, the white matter of all these different networks, VAN, CEN, salient and sensory motor, which are all around this tumor, and I modify my resection to maintain the integrity of the higher cognitive networks. So here's the operation, here's the tumor resection, and you can see on the post-op scan that I actually left that bit of tumor there. It may not have been tumor because the preoperative scan showed that there were functional parcels in that part of the brain, and a very, very good outcome. Now I use Connectomics to prehabilitate this patient. So we all know about what rehabilitation is after we damage someone, but can we do something to a patient before surgery to lessen the damage from surgery? This patient had a tumor in the left temporal pole. Now, again, pre-Connectomics, I would have just gone and done a polectomy. I would have taken away the temporal pole thinking that I was doing very safe surgery. But in fact, if you map this patient, you'll see that language is very, very intimately related to the temporal pole. So these are parcels of language. These are parcels of accessory language, not just speech, but phonetic and semantic language, visual language. All the different parts of the language network can now be shown to be around this very, very isolated temporal pole lesion. So what do? I take the patient to prehab. We take the patient to prehab and we use the scans to down-regulate the activity of this area. So this is a scan, a matrix showing these areas or these parcels around here. Reds means they're overactive. We can give the patient TMS at our clinic, transcranial magnetic stimulation, and we can aim the magnetic field at these red areas, we can use theta burst stimulation, continuous theta burst stimulation, and down-regulate the activity of these areas and show that, in fact, the post-TMS scan shows that it's very, very quiet now. What that does is now hopefully make surgery safer because those areas or those functions are being subserved by other areas of the brain. So we can take out that tumor completely, complete resection, and we can get a completely normal patient from a language viewpoint. Now, if we do cause a deficit, we use interventional accelerated neurorehabilitation, or IVAN. IVAN is the ability to enhance someone's recovery using transcranial magnetic stimulation after you operate. So here's a man with a thalamic glioma. You can see that it's in a very sensitive area. You could easily damage this patient, and I did. So I created a right hemiplegia. The arm is completely weak. The leg regained some function so that by day 6, he had 3 on 5 power in his lower limb, but 0 on 5 power in his upper limb. So he commenced transcranial magnetic stimulation. These are the maps that we used. I won't go through them, but essentially, I'll show you how he improved with TMS. So this is a man who had a dense hemiplegia from a GBM, and this is 7 days after TMS, showing a very rapid improvement. The sort of improvement you might get 6 or 12 months later, but he got 6 weeks later. This is his improvement in the lower limb function. He can't lift that leg off the floor. We give him 1 dose of TMS, just 5 minutes of TMS, and he can then lift his leg up. And then after a few days of TMS, he's walking with 1 assistant. And this is 2 weeks after TMS, he's walking even without an assistant. This is a letter from his family. 12 months later, he's no recurrence of his tumor, doing well. This is him almost 3 years after his GBM removal, still doing well. And this is him now 4 years after IDH wild-type thalamic GBM, complete resection, and he's enjoying very good quality of life. Here's another patient in which I used IVAN. This is a hippie patient who didn't want to have radiation, and this is a recurrence. This is my first resection of an anaplastic astrocytoma. Rather than have radiation, he asked me to take this out. We mapped him, and there were basically functional pathways within this. And I told him that to take this out, it would definitely paralyze his leg. And so here he is after surgery with a definitely completely monoplegic lower limb. And again, the sort of lower limb that you wouldn't expect to get better for at least a year or 2 years, given that I resected his motor strip. But we start TMS pretty quickly. Day 3, we started TMS on him. This is him walking at day 5. Day 3 TMS. And this is him showing even some foot movement and balance at day 7. Post-op, day 5 TMS. And this is him surfing 2 weeks later. It's not just us doing it. This is an article from the team in Charité in Berlin, Germany, and it's basically level 1 evidence. So it's level 1 evidence that navigated repetitive TMS improves the outcome of post-surgical paresis in glioma patients. It's a randomized double-blinded trial, so everyone should be doing this. Anyone who does brain surgery who gets a post-operative neurological deficit, now there's level 1 evidence to show that you should be giving them TMS to improve the overall outcome. So in conclusion, knowledge of the networks has revolutionized our understanding of the human brain. Identifying these higher order networks will better inform our patients of risks in the consultation process, aid in the planning of interventions pre-treatment, and reduce the adverse effects of surgery intraoperatively. Furthermore, by combining accurate, comprehensive, and personalized structural maps such as QuickTome with functional information such as QuickTome FC, we will improve our ability to modify anomalous networks and subnetworks with any brain disorder using minimally invasive interventions such as TMF, both before and after surgery. Thank you.
Okay.
What I have learned is how to recognize where you went wrong in your past. That was the most important message, to accept that was wrong and then you corrected it. That was the best of the messages you have given to us. Excellent talk. Thank you. You are always great like this. Now I request Professor A.K. Singh sir to come and give his talk over here.
Thank
Professor
you.
A.K. Singh has
Good evening, everyone. Good evening, Professor Teo, Professor B, Professor Dua, Professor Bharti, and Dr. Uday for giving me this, for inviting me to join this. Having listened to Dr. Teo, I am, beginning to wonder whether I should continue speaking at all or not.
sharing our screen.
I have no slides to discuss, so I will merely be talking. Because my talk was primarily for a situation wherein one is faced with a situation wherein a person has a problem. You don't have that kind of a technologies, that the wonderful technologies that Dr. Teo talked about. But after having listened to his talk, what I would like more than anything is to ask him questions rather than talk, rather than waste time. But anyway, since I have to speak a few things that I must speak, because we do have a situation in this country wherein either the technologies are not available or the technology might be available but are not used adequately. So how did we basically land up? I'll say a few words for about 5 minutes and then would much rather like Professor Teo to answer quite a few queries that everybody has, and so do I have. Incidentally, Dr. Teo, the results are excellent, the ones that you showed, in terms of the functional recovery, especially the IVN, the use of IVN. And I always thought that one would use TMS much later than what you people are doing. Fantastic. But coming back to what I was supposed to be talking about, that was before the development of neuronavigation, navigated surgery. What were we doing? How did we come to the navigated surgery? Did we ever at all manage to help some people or not? Obviously, not as well as what Dr. Teo showed, but we did manage to be accurate based on the same basic parameters that Dr. Teo showed. Now, what are those basic parameters that would be required, whether you're using a technology or not, are based on basic anthropometric knowledge. You need to know your anatomy. You need to know exactly what organ is normally supposed to be placed where, and its relationship to the surface. I belong to an era that was pre-CT, pre-MR era, and we had to plan our surgeries in the beginning during my training days based on angiography, ventriculography, and sometimes pneumoencephalography. And dare I say that we managed to enter using a small little hole. We did manage to do selective third ventriculographies by putting in a ventricular needle through the foramen maundro into the third ventricle, about 90% times that we attempted. And that required that you needed to have your anatomical knowledge, the surface markers, Taylor-Horton lines, and other markers very clearly etched out in your head. Similarly, when Dr. Dandy did his anterior third ventriculostomies or his posterior approaches, you needed to have your anatomy well so that you caused least damage to the areas that are concerned. What I'm finding is that in the presence of newer technologies in the form of imaging technologies, CT, MRI, what I'm finding amongst juniors is a tendency not to study the anatomy as intensely as we used to do. Rely a lot on the evaluations by others, which would then lead you into trouble. So whether the MRI and CT can be both, can be a blessing and can be a occurs in the sense that you stop imagining. At the end of the day, whatever you're going to do on anybody is, you have to have a 3D map within your brain as to this is what you wish to do. Whether you're using a CT, MRI, angiography, or a connectome, you need to be able to imagine that what you are going to do, your intervention, the probes, the surgical instruments that you're going to use, where would they land up? So the surgery cannot be separated out from that. That's basic tool, which is something that unfortunately I'm discovering that a lot of people are not using nowadays. What a word of caution that I have is that navigation would not work by itself. We're relying too much, because if you do not, as Dr. Teo showed very well, if you're not aware of the different anatomies and the different organizational structures, no matter what kind of a pre-op imaging you've obtained, you would still not be able to save the structures that are meant to be saved. And obviously, as you showed very well, that the so-called classical approaches are no longer viable, are no longer required. You need to be looking at your MRI from or CT from 3 different views. They're complementary. They're not one single view. All the 3 of them have to be either you have a software which will do it for you, or else you'll have to do it in your brain and fuse the 3 images in your head, and then plan your trajectory accordingly. The trajectory that would cause the least damage. So therefore, a good amount of precision surgery is possible, but obviously you may land up giving subtle neurological deficits, which Dr. Teo talked about, the cognitive defects, etc., etc. And well, if technology is available, then one must be using the technology. I don't think I have anything more to add to this discussion at this point of time in comparison to in relation to the use of neuronavigation. So if the organizers will permit, may I take the liberty of asking my fellow speaker, Dr. Teo, about a few things, if Dr. Teo would agree. Dr. Teo?
I'm here and I'm ready to answer the questions.
No, excellent results. No doubt about that. And I wish I was a bit younger to be learning those things, but I suppose never too old to learn new things. About some of the questions that these boys were asking, and I think I also asked, one of the questions that I wanted to know was that lady that you showed, who had a frontal lobar, frontal polar tumor. Now, you mentioned that your surgical intervention, which was excellent, led to her having different emotional problems, right? Now, what I would like to know is that the tumor was destroying those areas anyway, right? The tumor that you took out. So you may have caused some additional damage by taking out the surrounding tumor, the normal brain around the tumor, right? Otherwise, the tumor part was already destroying. So how would you explain that?
She had a well-circumscribed low-grade ganglioglioma, and the margins were quite clear. I went in with the express purpose of performing a supramarginal resection because she was young. She was only 32 or 34, and I wanted her to live for as long as possible. So my major intention of surgery was an oncological good outcome. And again, it was a teaching from my forefathers that said that I could do a supramarginal resection because it's the right frontal pole, that then gave me permission to do that supramarginal resection. I would love to say that you were right. It would take away a lot of my guilt, but I think you're wrong. I think if I had stuck to the tumor margin and not done a supramarginal resection, her outcome would have been much, much better. I think I with my aggressive resection, all good intentions, was the cause of her change in personality. It was dramatic. I ruined her life. Before surgery, she was a hostess on a big yacht, those really rich people's yachts, and so she was gregarious. She she could interact with people very well. She could multitask. She was a good organizer. She was very, very outwardly going. And after surgery, after my surgery, she was a completely different person. Completely different. Lost all her working memory, couldn't interact with people, became depressed and anxious. And again, I knew that, but I thought that she was a bit crazy because I didn't realize, well, I didn't know what the central executive network was. I didn't know what the default mode network was. And I certainly didn't know that those networks were represented in the right frontal pole. So I didn't blame myself for her outcome. You saw my notes. My notes were of someone who was incredibly irritated by her almost accusatory claims that her surgery resulted in her this change in personality. And every time she implied that or said that, I'd say, no, you're wrong. The right frontal lobe's a very non-eloquent part of the brain. I couldn't have done that. I couldn't have affected your memory. The memory's in the left mesial temporal lobe. It's not in the right frontal pole. But I was ignorant. I didn't know the difference between long-term, short-term memory and working memory. And I affected her working memory and I affected her personality. It was totally from the supramarginal resection.
One more question in relation to this only. I'm sure this is not the only one that you operated, who had a person who had a frontal polar lesion. I'm sure in your long career you must have operated on many such patients, or
Yes.
your seniors might have done. Do you encounter it every time, or is it sometimes?
Well, I never looked for it. Again, I blame myself for doing a neurosurgical examination. They would come in, I'd get them to put their hands up, I'd look for a pronated drift.
Exactly what we all do. Yeah.
I'd test their language, I'd check their visual fields, and I'd ask if they've gone back to work. Invariably, they hadn't gone back to work, but I put that down to brain surgery, steroids, plus or minus radiation, chemotherapy. I never blame myself. I never blame the surgery. And so the answer to your question is, if I had looked for it, if I'd asked for it, if I knew the questions to ask, I would imagine that probably at least 50% of them, if not more, had some high cognitive network dysfunction. But I never asked for it. And like I say, neuropsych evaluation sometimes doesn't pick it up. If you look at the salience network, for example, the salience network controls all those functions that we lump it together and we call it interoception. Well, what is interoception? Interoception is very, very nebulous. It's very non-tangible. It's things like the ability to have an orgasm, the ability to feel the pain of others and the pain of oneself, empathy, all these functions. And I challenge anyone in this audience, how many times have you asked your patient when they come back from glioma surgery, do they have an enjoyable orgasm with sex? We don't ask them questions like that. And neuropsych evaluation doesn't ask them questions like that. So we are missing all this information. We're ignorant of it. And, and for all we know, 100% of patients may have some higher cognitive dysfunction.
Quite true. Quite true. Possibly because we just don't look for it, so therefore we don't know. That's probably the best explanation for it. There are many other questions for you, Pradeep.
Sir,
there are other questions that
later on. Let us have a short thing from Brainlab, then we can do it.
Okay.
Similar purchase happened in emergency area also. Please ask.
Yes, sir. Upward approval for procurement of 8 number A type oxygen cylinders. Anemia for an issue.
Good afternoon, everyone. Can we go to the first slide?
ये वहाँ से फाइल चली थी आकाश जी से,
तो किससे मांगा है उन्होंने क्वेश्चन?
ये अपने यहाँ से मांगा है ऐसा हुआ।
किसने मांगा है? ह्यूमन प्रोक्योरमेंट था क्या? मनु डीडीए ने भेजा है
Can
हमारे
we go
यहाँ।
to the first slide, please? Good afternoon, everyone. I'm Nitin and I represent Brainlab. First of all, thank you very much for giving us this opportunity to come over and present and talk about Brainlab and the technology solutions that we offer. Brainlab, as far as an organization is concerned, we have been offering amazing advanced high-tech medical technology solutions. And we almost started our journey 3.5 decades back. I'll first take you through our head office, which is in Munich.
Note number 6 may be referred.
So that's what is Brainlab headquarters in Munich. This used to be the Munich airport in early 90s. So we have taken the entire airport complex area, and this pink colored tower that you can see here used to be the ATC tower of the aircraft. All these were the passenger gates and the tracks, aircraft taxi tracks. So all these entire premises is part of Brainlab now. We have a Michelin 5-star rated restaurant here, which is highlighted here. We have dedicated 8 ORs with bunkers, wherein we have placed the actual machines with our partners, starting from linear accelerators to all the latest microscope models and various integrations that Brainlab offer in health tech space. Talking about our journey, we started almost in late 80s with some amazing and advanced solutions. There have been exciting solutions over a period of time, but off late in the last few years gone by, the new age tech solutions that we have introduced also talk about the advanced data enrichment solutions and robotics, the direction in which we are going. Of course, I will be talking and dwelling a bit more upon these solutions. I also saw some amazing details that Dr. Charlie shared with the 3D data and various structures which were segmented, especially for the functional perspective. We'll also see, like, if there is a time, we can also have a demonstration of some of the 3D visualization mixed reality solution that we have recently introduced. As far as the planning part is concerned, Brainlab offers amazing pre-op planning software. These softwares can be installed on a server on a dedicated computer system and can be accessed from any other part within the hospital network. Starting from the segmentation on the initial part, wherein initial contouring for the patient can be done with the help of an AI-based tool. Only thing that the clinician has to do is on 2 slices, any 2 slices and the different orientation, they need to mark the tumor using the AI tool, and automatically the entire 3D would be reconstructed. We also have advanced segmentation solutions wherein the entire structures can be segmented automatically, even for functional procedures. We have advanced object management tools wherein clinicians can pick and choose what all segments they want to be defined and they want to visualize for a particular clinical case. And based on the atlas, which is already there within the software, they'll be able to visualize all these important structures. Moving further, as far as the 3D visualization part is concerned, the advanced 3D visualization software would help them to visualize the entire data in 3D. They'll even be able to do the entire cropping of the entire structures in 3D and can visualize various parameters from multiple angles. The entire 3D structure can be rotated. We offer advanced solutions for data fusion, wherein multiple data sets can be fused with each other, be it MR, CT, PET, SPECT, or any other imaging modality data. They can be fused to each other, and everything is done automatically. You can also check the verification using a spyglass. Now, this being a static image fusion, wherein one image is fused to the other one, but specifically talking about cases wherein very heavily distorted data is received. Let's say if we talk about the functional data, because of distortions, the imaging cannot be precise. And that's where we actually have our elastic fusion, which is known as distortion correction, wherein the distortions can be corrected by the software. The sections in the red, which are highlighted here onto the image, have a lot of distortion. And if you zoom onto the image, you'll find that the fusion has been done elastically by the software itself. Similarly, we have been offering solutions for functional procedures, starting from a dedicated module, which is called Elements, for stereotactic procedures, which will help with the ACPC coordinates. There is a dedicated module for Elements for lead localization for functional procedures, and then a dedicated module for tractography. The DTI datasets can be converted with the colored fiber tracks and then can be visualized in 3D. Along with that, a brain projection view is also visualized. You can define your area of interest, and within that section, software would automatically populate the structures and the fibers which are there in that vicinity. Besides that, Brainlab also offers bold MRI mapping elements. Now, this is blood oxygen level dependent solutions, wherein the important areas within the brain can be demarcated clearly. We have both the variants here, that being class-based as well as resting state. Specifically for trajectory planning, we have a dedicated module. Of course, all these solutions will be able to visualize in the later part of the session. Once we have the actual hands-on the demonstration, we'll also be able to visualize these solutions using our mixed reality solutions in 3D. So the structures can be visualized with all those precise information. Let's say if it's a pre-op data set in MRI and intra-op CT is available in the hospital premises, you'll also be able to have this assessment of virtual IMRI, wherein the data set can be upgraded using the solutions and software. Besides that, there is a dedicated module for vascular procedures for the contouring as well as the fusion. Now, these being solutions which are broadly on and about the planning part, but usually when the patient is approaching a clinician, they have a lot of questions on and about how the tumor or how the surgery would be performed. Their relatives have certain number of questions. Now, we have this advanced mixed reality solution viewer, wherein clinicians would not only be able to give in-depth details on how they are going to do the treatment, even the patient and their relatives would also be gaining a lot of confidence in terms of what the actual challenge is all about. You'll be having an access to patient data in 3D. You'll be able to rotate the entire structure wearing these 3D glasses. I'll just share a small video with you. Can we play the video, please? So usually when the patient is approaching clinicians, they would be for sure guiding them as to how they'll be doing the procedure. But wearing these 3D glasses, once they have done the entire planning, they'll be able to scan the entire plan, and the plan gets transferred from their planning system console onto the glasses. They'll be able to visualize the entire plan. Even to an extent from academic perspective, if the clinician wants, they can put annotations as well on the various structures. You can zoom in and zoom out. You can have brain as big as the size of this hall where I'm making this presentation. You can have collaborative sessions wherein all clinicians and the clinical team can discuss on a particular case. Can also be a strong tool for tumor board meetings. You can remove various layers, starting from bone and skin, and go to the other sections and the organs that have already been defined there. You can rotate the entire structure in 3D. Now, this is a module which is already released. Just last week, we have released another add-on module wherein these glasses can also be worn in the sterile field in the OR. So already, first two cases have already been done in Europe. So Norway and Ireland, there are two centers who have already done 2 cases. Product is already CE approved for clinical usage. So this is going to be the next generation wherein all the hardware boundaries would be eliminated to a greater extent, and clinicians would be able to use these glasses in the sterile field. Talking about the navigation platforms, we have been offering these 2 navigation platforms of late, one being Kick, which is a portable navigation system. And along with that, we also have Curve, which is our advanced high-end navigation systems for broadly focused on intraoperative procedures in case you want to integrate multiple devices with the navigation system. As far as Curve is concerned, which offers a 4K resolution along with that mixed reality combination, lots of advanced features which can be integrated with this navigation system, including to an extent the latest generation microscopes, ultrasounds, and exoscopes. We also have a ceiling mounted solution, Buzz Navigation, which is for primarily dedicated OR. and acts as both a combination of a digital OR as well as navigation. As far as these digital solutions are concerned, they also offer add-on features like audio video conferencing, streaming of the data, surgical checklist, which is digital. All these parameters can be covered and the entire patient records can be kept in a single folder. So very wide range of navigation portfolio. Brainlab offers broadly these solutions which can be used across applications ranging from cranial, spine, ENT, and craniomaxillofacial. As far as the patient data registration is concerned, it can easily be done using the laser-based registration, wherein laser pointer is pointed towards the area of interest, and basis that the points are acquired, and patient is registered in less than 15 seconds. There's also a virtual craniotomy option here with the navigation system. Apart from that, vascular navigation can also be done using Brainlab navigation system. As far as the advanced devices and their integration is concerned, Brainlab offers microscope integration with all the latest generation of microscopes available across the globe and their advanced function, including their robotics function. This is a clinical case which was done sometime back in Delhi, its center. Even to an extent, the brain shift compensation can also be done, wherein the corresponding vessels or structures can be aligned and overlaid. And then the brain shift compensation can also be taken care of using microscope. Apart from that, we also offer advanced AI tools wherein from the ocular, since we are only visualizing 2D structures from the uppermost layer, we'll even be able to rotate the entire structure upside down and rotate so as to visualize what is actually lying beneath. Moreover, in order to assess specifically brain shift parameters, we also have a complete end-to-end digital integration with the latest available ultrasound models in the world. So brain shift assessment can be done using ultrasound integration with Brainlab systems. So very wide range so as to assess these important parameters, starting from ultrasound to microscope to intraoperative CT or MRs, and even to an extent, the robotic imaging that Brainlab offers. Centers can pick and choose as per their clinical requirement as to what would be more apt as a solution for their center. The same navigation systems can also be used for spine and trauma, wherein we offer complete integration with imaging robots, latest generation of 3D C-arms from leading players like Zyme, G, as well as Siemens. And apart from that, all the available major models from various players in CT, they can also be integrated. And then there is also a manual registration option of surface matching. All your existing instruments, be it your awls, chisels, and probes, can be calibrated and integrated with the navigation system so as to give you an ease of using your own set of instruments during the surgical procedures. You'll be able to visualize your instruments on the navigation monitor. Even interbody navigation like cage navigation can also be done with Brainlab solutions. Brainlab also offers microscope integration for spine procedures, specifically for spine tumors. We have also come up with some exciting new age robotic solutions, starting from robotics, wherein we have our advanced imaging robot, Lupex. Now, Lupex is one of the widest bore imaging modality available across the globe. It is an imaging robot which can easily be moved around in multiple ORs, can be easily moved using the handheld pendant, which is battery controlled. The overall bore size of the machine is 122 centimeter. So even for very obese patients also, with all the spine instruments attached, they can be easily scanned. That's what the hand pendant is all about. There are already pre-filled templates, but you can also have your own customized set of templates. Now, these templates can define your area of interest. a laser would be guiding you. And then, of course, once the instrumentation is placed and patient is scanned, usually you find that all the imaging modalities would have a emitter and receptor at 180 degrees to each other, which is very unlike here. This imaging robot, where an emitter and receptor can move independent to each other, thereby giving you very, very flexible options for collimation as well as for non-isocentric imaging. Especially talking about cervical section, wherein I'm sure you would like to spare the unnecessary radiation to the cardiac section, you can actually go for a V-shaped kind of a scan, thereby reducing any possibilities of radiation exposure to areas which need to be spared. So all those scanned position and stored position can be there within the system. System would go back exactly at the same place in the parking bay. Once the screws have been placed, it would come back exactly at the same place in the orientation and would take the verification scan for you. It can be a 2D or a 3D verification as per your clinical requirement. Totally integrated with the robotic solutions that I will be talking in the next slide. So an option for 2D or 3D verification. We also have a delivery robot called Circ. Now, Circ as a robot has been built onto a unique concept. Usually you'll find that all the robots, they have very, very big, bulky footprint. Now, Silk is actually a zero footprint robot, which gets attached to your OT table rail. Now, this one single robot is also onto a modular concept, wherein this robot can be used for multiple clinical applications, starting from cranial biopsy, for cranial SEG procedures, and even for spine for pedicle screw placement. One single robot with the same robotic arm which gets attached to the OT table rail, and then apart from that, only thing that needs to be changed is the respective set of instruments and the software. With a very large range of motion, the robot can cover the entire spine easily. So one single robot for all these multiple clinical applications with zero footprint. And this is what we have as a combination called robotic suite, wherein all these devices are integrated to each other seamlessly, starting from curve navigation, LoopX imaging robot, and Circ, the delivery robot. So broadly, these are the solutions that we have in IGS or image guided surgery portfolio. Apart from that, even for radio surgery, we have some exciting range of solutions. Talking about ExactTrack, which has been there from last more than 25 years for patient positioning and verification, especially for radio surgery procedures. We have been offering various generation of these solutions, but the latest generation now that we have with us is ExactTrack Dynamic. This is a integrated camera system with ExactTrack Dynamic, wherein thermal and surface camera have been integrated to each other so as to offer you a complete experience. All the constraints which are usually associated with the surface only tracking have been taken care by adding thermal mapping. The system is totally compatible with the latest generation of Varian and Electa linear accelerators for high energy. Apart from that, Brainlab has also been already nominated last year for German Presidential Award for Technological Innovations. And this is basis the markerless tracking that we are going to introduce in next few months, wherein without any marker, all these important soft tissues would be scanned and tracked in a radiosurgery procedure. And that's what is ExactTrack Dynamic all about, the complete workflow as far as the solution is concerned, especially for cranial treatments. Once the patient is positioned, for patient positioning, once the mask is placed, the immobilizer, the section here, yeah, this is click and fixation. There are multiple type of mask options coming with the system. And then thereafter, basis the CT data, the patient would be positioned and the live surface camera would be able to track it basis the planning CT. Once a patient is positioned, X-rays at the floor would be able to take a verification shot, and you can verify if it is appropriate orientation or not. In case of any movement or any detection or any deviation, it would be informed immediately to the linear accelerator, and the correction can be done. The shift can be sent to the LINAC. After you have verified it, yeah, and then the dose is delivered using the linear accelerator. At every step, you'll be able to monitor the respective movements and the changes. You can also define as to what all angles there should be a verification using the images. You can define at respective monitor units or at respective gantry angles in case you want to take a verification scan during the radiosurgery procedure. The moment a deviation is detected, immediately it would be informed to the LINAC, and the beam would be put on hold, and then a correction can be done immediately onto the table itself without doing any additional CT or EPID related information. So that was in brief about Brainlab and the technology solutions that we offer. So now we'll be also having subsequently after Bharti's addressal on a actual hands-on demonstration. Thank you very much.
Thank you, Nitin, for your nice talk. I request now John to please moderate the session with our delegates, esteemed guests. John, please do help us in moderating the question answer session with the chat.
Okay. Okay, can you read the panel, what's written there in the panel? There's a couple of questions and remarks. Uday?
Okay. Yeah, just give me.
Uday to the rescue.
Thank you, sir. Question answers. Question answers. Any questions in the chat session? Yes, there we have. Camera.
Can you see the chat question?
Yeah, there are questions. I'm just putting them.
Okay.
There's a tip from Dr. Amitabh. Dr. Amitabh, can you come online and speak? Can you switch on your please, sir. Please speak.
Would Nitin be able to hear me from Brainlab?
Yeah, Dr. Amitabh Goyal is a neurosurgeon working in Max. He's doing endoscopic neurosurgery, sir.
Am I audible to Mr. Nitin from Brainlab?
Yes, sir.
Okay, so can we fuse the images and project them onto the operating surgeon's eyepiece? Which means when I'm operating and doing microsurgery for a transsulcal approach, like I mentioned on the chat, and I'm lost because either I look into the microscope or I can look into the monitor, your navigation monitor. I'm using your competitor's equipment. And so what I do is usually I calibrate the suction tape, and then the first assistant looks at the monitor and I peep into the microscope. So can we have the images, the live images, when I'm moving my navigation probe, can those be projected dynamically onto the operating surgeon's eyepiece? Is that possible?
Yes, sir, that's very much possible. So in fact, your section tip would be also integrated, but along with that, once your microscope is integrated with the system, the microscope ocular would also be able to give you an option wherein the entire navigation monitor would also be reflecting there. You'll in real time be able to visualize where you are, and the entire pointer and the respective set of calibrated or integrated instruments would also be visible with the microscope ocular itself.
Okay, so I'll need to check with my model maker. Thank you. Thank you, Nitin. Thank you.
Welcome.
So you want to give us a tip of navigation, please? Please, you can give us a tip and please brief us.
Mentioned in on the chat. So once you do surgery, your left hand holds the suction and the right one operates, has the bipolar forceps in your hand. And once you remove the bipolar forceps, then you take a navigation wand in your hand, in your right hand or your operating hand, your dominant hand, and then look for and track yourself on the operating field while looking at the monitor. So if you are able to configure your suction tip, which is possible, and then you are relatively free to spend more time operating rather than looking at the monitor. This is what I was trying to say on the chat.
Thank you, sir. Thank you, sir, for giving us the lovely information. Mr. Nikad, Mr. Nikad, he wants to speak to Dr. Charlie, sir. Mr. Nikad, can you switch on your mic, please? Can you on your video? Mr. Nikad Ahmed. Mr. Nikad, you there? Mr. Nikad was asking to Dr. Charlie, sir, what image sequence pre-op in glioma surgery be used for planning site of surgery using perpendicular plane line axis? Dr. Charlie, sir?
Well, it's very simple. You use the image sequence that shows the tumor best of all. And I think what he's getting at is, do you case T2? Do you resect T2 flare, or do you just go for enhancement? And it's a very difficult question because it's so variable and it's so personal. I guess I can give you a few caveats and a few surgical dictums. The first is that with a malignant glioma, the most important part is the enhancing portion. So with a malignant glioma, the edges are so poorly defined on T2 and flare that you don't know what is edema and what is tumor. So you basically go for the enhancing portion. With oligodendrogliomas, they're so well defined that you should go for the flare T2 because that usually takes you to the edge of the tumor. With diffuse astrocytomas, it's very difficult. With gangliogliomas and JPAs and those lower grade tumors, of course, you stick to the borders on T2. Do I chase T2 and flare? No. I'm sure you all are aware of Raymond Sawaya's article about chasing flare and chasing T2. I think that's wrong. I can give you so many examples of patients in whom I've resected the tumor. The immediate post-op shows significant flare residual or significant T2 residual, but if you rescan them 6 weeks later, no chemotherapy, no radiotherapy, all those T2 changes or flare changes have disappeared. In other words, it wasn't tumor, it was edema. So I disagree with the overall dictum that you should always chase flare or chase T2. I think that's wrong. I mean, I know that most of you have heard me talk before, and I apologize for sounding like a broken record, but the best way of taking out a tumor is not to use intraoperative imaging and intraoperative mapping and intraoperative biological dyes. It's to actually know how to recognize normal brain. In other words, when to stop. I was lucky enough to be taught by Yazhigil, so I had a great foundation of glioma surgery. Yazhigil taught me so much. But the one thing I've learnt myself is the use of the bipolar in determining that interface between normal and abnormal. The bipolar is just so effective that I'm very much against using the CUSA or any other machine to take out a glioma because the bipolars are just so good at differentiating that demarcation point. Tumor, no matter what grade, will bubble when you coagulate it. So if you use those big, nice, fat bipolars that to disperse the heat at the tip of the bipolars, then a glioma will bubble and melt. It won't char and burn. But once you get to normal brain and you use those bipolars, normal brain will burn and blacken and char. And that's a very, very reliable way of differentiating between normal brain and glioma. So those of you who've seen me operate, I do not use intraoperative frameless stereotactic guidance once I'm in the tumor. Well, most people don't because the brain is shifted so much anyway, but I certainly don't use it for determining the interface between normal and abnormal. I use what Yajigal taught me, and that is all the senses, and I use the bipolar technique and the bubbling technique. So Yajigal taught us that we should use every sense. The sense of vision. A tumor looks different. It has a different color. It often has a different consistency. You should see how it feels. Tumor is either softer or firmer than normal brain, and it moves differently when you push on it. You should use your sense of hearing. When you suck up a glioma, it sucks up like mucus, but normal brain never sucks up. It never sucks up like mucus. And then, of course, all the other aspects of normal brain. Normal brain has normal blood vessels, and those blood vessels look like little petechiae when they're cross-sectioned, or single small vessels when they're in longitudinal sections. It's whiter, it's more glistening. Normal brain never comes off in sheets. If it comes off in sheets, it's glioma. There's all these little tricks, and I can give you a talk for a whole hour or 2 hours on all the different ways of differentiating normal from abnormal. But I certainly don't think that those intraoperative aids help in determining the interface between normal and abnormal. I think all those other senses, the basic surgical tenets, are more important.
Thank you, sir. That was very informative. Dr. Vinod Kumar Tiwari, he wants to ask some questions. Dr. Vinod, please, you there?
Yes, sir.
Yeah. Good afternoon. Good evening,
Very
sir.
nice
Please
talk
speak, sir.
yeah,
you for
very nice
attending.
talk by Dr. CEO. Well, I got my answer as he has just narrated that like to exercise that T1 contrast, not the T2 or flare. So that was my first question. Second question to Brainlab. So if you are fixing T1 and T2, so do you have any technology so that those two shoulders which are coming in between that C-arm, either in basically lateral view, how can you eliminate those two shoulders? So do you have any technology so that those two shoulders be eliminated in the images?
Sir, in fact, you would request if you can please repeat the question once again.
Yeah, basically what if we tend to fix this one T1 and T2 vertebrae from posterior side, then both side of this shoulders, they come in view in C-arm in lateral view. So do you have any technology so that these two shoulders be eliminated from the lateral images, so that we can have the clear picture of T1 and T2 and the transparticular rule which is more accurately?
Yeah, I got your question, sir. So in fact, I did spoke about the robotic imaging modality that we have, which is LoopX. Now, the beauty there being that since the emitter and receptor, they move independent to each other. So you can have a collimated image wherein you can actually eliminate or crop the sections of the shoulders, and then you can actually define your area of interest. So let's say if it's C1 to C3, which is your area of interest, only that section would be scanned and there won't be unnecessary radiation to the nearby areas. So using a pointer, which will be a pointer tip, once you'll be placing it to the area of interest, a robot would only be scanning the area which has been demarcated by you. And it would eliminate the shoulders and other areas which are not required during the scan.
Thank you. Thank you, sir. Thank you.
So
I have a question to Dr. Professor Charlie, sir. Sir, can you brief us about the merits and the use of a keyhole surgery against conventional craniotomies, and how does it help us in lessen the morbidity and the discharge of the patient?
Well, again, I'm sure you understand, Uday, that this is a very controversial question, and It's very naughty of you to ask me that question because I will offend some people by answering it, but such as it is, I'm going to offend some people. So here we go. There are people out there who are such good surgeons that they get perfect results with large craniotomies. And so they say, when they hear me talk, why would we make it more difficult and possibly more dangerous for the patient when we're getting great results using big craniotomies or big openings? And my answer to them is that you're missing the point. Here's the point. The point is that if you use a small opening or a keyhole opening and the results aren't as good, then you're doing the wrong thing. The end point should always be the best neurological outcome for the patient. So if you make a small craniotomy and you get more neurological deficits or more complications, then that's not a keyhole craniotomy. That's a ridiculously small craniotomy that's inadequate. A keyhole craniotomy is a craniotomy that gets the same good neurological results as a large opening, but even more benefits, i.e. shorter operative time because the incision's not as long, so you don't have to burn as much skin, burn as much scalp, or take away as much bone, less blood loss, less denervation of the scalp, less exposed brain, shorter operative time because there's less time in closing. It's a ridiculous argument. I don't even know why traditional craniotomy surgeons even argue about it, because if you say to your patient, look, I can take out your tumor with excellent results and I can do it through an incision this big, or I can do it through an incision this big, who's going to say, oh, I want you to do the big incision? I mean, no one. That's ridiculous. It's just a ridiculous argument. And but the trouble is there are so many surgeons out there who have achieved their eminence by doing big openings. All those skull-based surgeons who do COZs and bicoronal incisions and question mark incisions and terional incisions, and they have achieved their eminence from these large cranial openings, and so they're very reluctant to change. So the bottom line is, as long as you can get the same results, if not better results, from a smaller opening, then of course you're going to do the smaller opening. If you keep getting smaller and smaller and eventually you increase your complication rate or you reduce your surgical resection rate, then you've gone too far. I remember operating with an ENT surgeon, and he was used to all the other surgeons doing a big retrosigmoid incision with a big craniotomy. And whenever I did an acoustic with him, I did a very small keyhole retrosigmoid craniotomy. And he'd go, Charlie, this is so difficult for me, and it's more challenging for me. And I remember saying to him, well, is it all about how easy it is for you or how good it is for the patient? So, a big craniotomy is easy for the surgeon. You don't challenge yourself. You don't have to get out of your comfort zone. You don't have to upskill. You don't have to get new equipment. You don't have to know how to use the endoscope. You don't have to adopt and buy single shafted instruments. Of course, it's easier for the surgeon, but we're not here to make our lives easy. We're here to make our patients get better outcomes with less morbidity and less collateral damage. So yes, it is harder for the surgeon. It's challenging. You get out of your comfort zone. You have to upskill. It's difficult for the surgeon. I'm going to be the first to say that, but it is better for the patients. They recover more quickly. There's less pain, less blood loss. And we've published our results with keyhole craniotomy. And, we published our paper on retrosigmoid craniotomy, mini retrosigmoid craniotomy, 890 of them, and only 2 cases of post-craniotomy headache. And if you look at the literature, after a standard retrosigmoid craniotomy, there's a 10% incidence of headache after that, chronic headache. We only had 2 out of 890. So, patients do benefit from the smaller craniotomies.
Yeah, thank you, sir. That was a wonderful explanation. I agree. It's an evolution. A keyhole is an evolution of a neurosurgeon. He has to learn it on by himself, mastering his own techniques gradually. Thank you, sir. So, a question for Dr. A.K. Singh, sir. So, how do you contemplate the future education of the country? How with the newer technologies and the newer approaches and the traditional ones, would you like to marry both of them? How would you like to evolve us and present this to the next generation?
Dr. Thank you, Uday. As Dr. Teo mentioned, you can't, you will not be able to adopt the new technologies until you master the older ones. So the older ones have to be mastered, and the older base ones remain the basics. As we were talking about the difference between the normal brain and the tumor brain, which is based on feel, which is based on color, differentiation, which is in the surgeon's eyes, surgeon's mind. So, and then the study, the preoperative study of the imaging and correlating that with the patient's clinical condition, that has to be done. The more you examine, your pre-op images, the more accurate you would be, and the more accurate you are, the less damage you'll cause to your patient, which is the bottom line, as Dr. Teo has repeatedly said that. The aim primarily is not to make your life comfortable. The aim is to make the patient better. So you need to know your gross anatomy, you need to know your macrosurgical anatomy, and you need to be able to correlate what you see in the images with the anatomy that you see on the table. So both have to be seen. So it requires a lot of effort. As I mentioned, I belong to the pre-CT era. At that point of time, we had to imagine a lot, 3-dimensional. And that required for us to get into our heads as to how a particular thing would be located, where it will be located. That hasn't gone. When you're going to the posterior fossa, for example, you need to know where your nerves would be, or where your vessels would be. Everywhere it will be the same. So they were combining the two.
So very well put together, sir. That means the education has to go on, and we cannot simply just jump onto the instruments and grab the instruments. We have to learn everything basically from this.
The anatomy will have to be learned in an anatomy lab.
The landmarks and the points and the sulcal kinematric points. So, and with the navigation, what do you suggest the younger generation should do in his learning venture?
I remember Dr. Yasagal once, way back in the 80s, he was in a conference in Hyderabad, and a lot of people wanted to visit his center. In those days, visiting out of India was a very tough job. Professor Yasagal had gone into the gullies of Hyderabad. So he said, if you want to learn microsurgery, you need to visit your own silverware and other artists who are doing fine filigree work without using microscope. Basically, microsurgery is eye-hand coordination. The more you do, the better you become. So anatomy, other things, your anatomical landmarks are fine, your surgical tools are fine, but until your hands also coordinate with your eye, the eye-hand coordination is there, the finish will not come. So I've seen people make mistakes even with the stereotactic or a neuronavigation instrument.
Yes.
Right? So therefore, a combination of the whole lot of things are required. And as Dr. Teo has repeatedly shown in today's talk, excellent talk, that when something is not, when patient is complaining of something, don't brush it off as the patient's wrong impression or whatever. Look back as to what you did. Review everything that you did. And that's how we learn. We learn by steps.
So, do you think the keyhole should be taught from initially, or is it again like is it the learning of the neurosurgeon himself, or it should be taught? I mean, during your training years, it should be
You
incorporated that.
you need to know both. You need to know about the larger steps as a part of the history also, and sometimes you might require it. You possibly require it in trauma surgery.
Yes, sir.
You would require, so you should know how to do that also, and also you should know about the parole. I mean the mini craniotomies and small opening surgeries also.
Yes, sir.
So you require both varieties.
Thank you, sir. Last question to Mr. the Brainlab representative. Does your Siri robot incorporate the spinal endoscopes also? I mean, when we are doing an endoscopic like a transforaminal or a UPE, something like that, will that work there also?
Sir, in fact, as far as the robotic module is concerned, at this point in time, the module is released for these three clinical areas, that being cranial biopsy, and along with that, even for pedicle screw placement. There are new age solutions also which are in pipeline onto which we are working, and regulatory submissions are underway. But since it's a modular concept, but I'm sure like in time to come, there would be new solutions added on top of.
Thank you. I hand over the dice to Dr. Pradeep, sir. Uh,
Thank you. Thank you, Dr. Uday. Now I'll call Dr. Abhinav to please give a vote of thanks if there are no other questions.
Any questions from the audience, please?
Dr. Abhinav Bansal.
Any questions? Good questions. Anybody wants to like you can switch on your screens and you can interact with this our senior faculty or the faculty on dais.
I think we are at the end of this wonderful session. Good evening once again. It has been such an honor to be part of this international hybrid event. On behalf of Swami Vivekanand Swabharti University and Department of Neurological Surgery, Subharti Medical College, I take this opportunity to express my heartfelt gratitude and thanks to all reputed guest speakers, delegates who have joined us in person and through virtual session. I felt obliged to express my sincere thanks to stalwarts of neurosurgery from national and international platform. Professor Dr. A.K. Singh sir, Professor Charles Teo, our Dean and Professor Dr. Pradeep Bharti Gupta sir, for sharing their insights and leading us to this important landmark session. I think it was well concluded with we should know our basics well, and then we should always have a goal to go for a more better technological advancements, which can help us to have a more better precision and will definitely help a much better functional outcome for our patients. With this, I would like to thank John for his relentless service and commitment through Neurosurgical TV to give us an international platform. Would also like to extend my thanks to the Brainlab team for providing technological solutions to this changing era in neurosurgery. Last and foremost, would express my thanks to our team members and our special thanks to our IT team who has wonderfully organized and conducted this session without a glitch. I would also like to thank Dr. Uday Gupta for taking this wonderful initiative at our medical college, and my other colleague, Dr. Vivek, and myself as a part of this scientific team. I would also thank all the delegates, students, our team in our OT and our ICU residents, ICU staff for giving us this opportunity to share our knowledge with you all. Thank you, one and everyone.
Thank you, Dr. Abhinav. I would request Mr. Brainlab to demonstrate, have a show session of their 3D technologies and their other things. Mr. Nathan. Oh, wait. हम लोग बाद में देख लेंगे Online session, online तो चल ही रहा है ना? Online session is still on. Mr. Nitin from Brainlab will be demonstrating his various equipments from Brainlab. I hand over to Mr. Nitin now.
My colleague Nitin Saxena and Himanshu are demonstrating our navigation systems.
So the first step of every navigation is you need to have a CT on MR. So, and that too with the navigation protocol. So what navigation protocol means is you need to have a 1 mm cuts so that the data can be reconstructed in all the planes, axial, coronal, and sag. So that is the one and the only requirement to have a uh, uh, to do the navigation with the systems. So once you have the data, the first thing that comes in mind is fusing the MR and CT. So we can do fusion of PET, SPET, and all T1, T2, everything. After the fusion, the first and the very basic step is the registration. So registration is something uh, which is of the most important step, but yes, often taken as, a step which is not very carefully taken. So the main idea behind registration is the patient which is lying on the table and the patient data that you have given to because all the systems are stupid. It's the human intelligence that will have to work. So the idea behind registration is the patient which is lying on the table and the data that you have on the navigation should match. It will only match when the bony landmarks are. So we used to give, or any registration or any navigation company gives the bony landmarks. So those bony landmarks of the patient will match until and unless the data is very old or the patient has a trauma and the anatomy changed. So the first step is registration. Now we have many registration methods. One is the automatic, in which the scanners are involved. So be it CT, be it a MRI or an NGO, we can do an automatic registration, which means when we do when the scan is taken, something is attached on a reference frame is attached on the scanner, and once the scan is done, the data is pushed to navigation automatically, and the system and the image is registered. So that is automatic registration. The other option is manual registration. Now in manual registration, there are two things we have. One is a surface matching registration that includes, so with this, the tip of the pointer is skin sensitive. So the moment you touch the skin, it will acquire the points. So it has a LED that it will show. So the moment I will touch the skin, it will acquire the points. No need to push or slide it, because once you slide, there can be a skin shift that will automatically add up to the inaccuracies. Yeah. So the other option that we have is the laser registration, which is touchless registration. So you don't have to touch, and with just the laser, you can register the patient. So this is the device. You just have to point the laser at the area which is shown, mostly the bony landmarks, and then the complete patient is registered. So it is quick as 10 to 15 seconds. It will take all the multiple points on the surface or the bone, and it will register within few seconds of so you see the registration is done. So once the registration is done, you can verify the registration accuracy of registration with the pointer. Now, once you are okay with this, you can go and accept it. If you're not okay with this, then you have the option of either re-registering or adding more points to it. So once you have done the registration and you have accepted the registration, now you come into the navigation part. In this, so there are different options. You can view simultaneously both the CT and MR. So because we are skipping the pre-planning part. So if you have the pre-planning, then you can do all the planning over here. Starting from the first, which every surgeon has suggested, like you need to have a good understanding on the viewing part, which is understanding the anatomy, and therein comes the viewer. So this is the viewer 3D that will give you so this you can always so suppose I want different planes of this. If I have a angio scan, I can get the vessels. If it's a contrast scan, I can get the vessels also drawn automatically by the software. So I can have the different planes wherein I can actually understand where or what my approach should be like. So this is the first among many, the first in the planning. Then comes your fusion, wherein the system does the automatic fusion by itself, and it gives you a fusion tree wherein if you want to select, although the system selects the best scan data which is available for navigation, 1 mm slice thickness, and it will fuse it automatically. You can verify it with the different tools that are available. One is the spyglass. The other is the blending tool, wherein the different data sets are marked with different color codings, and you can just slide and you can actually view the preciseness of the fusion. After this, the fusion, you can use the smart brush, which is a manual marking tool. So you can outline the anatomies, you can outline the tumor. So earlier, when we used to mark it, we used to mark it. When it's a 1 mm slice thickness, you'll have 192 slices. So you will have to mark in, first 9 and then 9. So there are different methods of marking it. So usually that was the practice which was done earlier. Now the softwares are coming, have become so smart. You just need to mark it in either of the plane, maybe axial, maybe coronal, or maybe axial or sag, something, and it will not mark 100%. It will leave some, but 95% of the work it will do for you. And you just have to, scroll and verify whether it has marked correctly or not, and then you can mark it. So this is called manual marking. So supposing, yes, this is touch screen. So this is one of the model that we have. The other model, what we have is the high end, that is curve navigation. This is called kick navigation. So that curve has some additional functionalities, as in a 4K screen, 32-inch 4K screen, and some more connections and all those. So you have the option of PAX, which is LAN connectivity, or the pen drive or the CD drive. All options are yes. So over the cloud, you won't be, yeah. So there is an option of a cloud also. It's called Quintry in our case. So if you load the data on that, you have the Quintry login ID here. You can pull the data from the cloud also. Yes. So that also. Yes. So configuration depends upon the surgeons or need. Suppose you want, because if you're going for a functional planning, you won't be doing on the navigation, because it's in the OR. You need something to be, which is, connected in your room. So we give solutions. One, maybe a standalone planning system or a laptop. You can buy the laptop. We can give the softwares onto your laptop, or a server-based solution. So in a server-based solution, a server, it can be given by us, it can be purchased by you also. We can put the softwares in that. So you buy a server, you put it in a server room, and 3 people at the same time can access and do the planning. So options are available. So if you need, yes. So we say on the fly planning, like it's on navigation. If you want it, you can do it, everything on navigation. So this is there in the system. There consists of two parts. One is the display card. The other is the camera card. So this is optical system. So this is optical camera. Now all the connections related to LAN or CD are at the back side of this. So if you come this side, then you'll have all the options. You can connect an additional source. You can connect the microscope and everything. So all the connections are available on this card. USB 3 network ports are there, and BNC connection. Yes, yes. With an exoscope also coming. Yes. So we are still working on that. So, but it will come. Like a can buy a third party. Yes, yes. Yes, yes, it can be done. So there are different flavors available. So if you have a different screens, we just have to take the output and plug it in, and that can be viewed. Yeah, it will not. It will not. So therein the matters is the output that you take to this. Yes, if you take with the HDMI, if you go with the BNC, yeah, if you go with 4K, it's excellent. But if you go for the BNC, there will be a signal loss. So that is, I'll not jump to ultrasound. This is something which comes in ultrasound also. So the idea is what we have seen is there are lots of ultrasounds are available in the market, being a 2D, 3D. Yeah, but the thing is, sir, earlier there used to be analog ultrasounds. Now there are digital ultrasounds. Image quality is better. The only thing is interpreting what ultrasound image with the navigation. That is the biggest challenge. So that is somewhere where the ultrasound company comes in and teaches the how it is correlating with it. Now the advantage with us with the ultrasound is we integrate the ultrasound in a digital manner, not with the analog cable, with the digitally, that is via LAN. So then we acquire the images. So there are two modes in ultrasound. One is live 2D image. The other is live 3D acquisition. So when we acquire image, so we merge, we put the live intra-op ultrasound image onto pre-op MR. So it is just in projection. But now we have come up with one solution with the help of Dr. Moidi. So he has conducted some clinical research and he has developed one app for us, which will correct the brain shift. So what we think is the navigation is only good till your craniotomy. Once the brain shift has happened, you cannot rely on navigation. You need that's why you use microscope, because you need to see from the naked eye the exact things. But now we have some solutions which can compensate or correct the brain shift. One is being the microscope, the other is the ultrasound. With microscope, you cannot acquire the images, but at least you can do the registration update. So once you have opened the dura and your brain has shifted, now you cannot rely on navigation. Now, the first thing that you will use is always the microscope. So we have something with microscope that we can compensate for the brain shift. So with the cortical vessels, when you match it, so it will correct the brain shift. And now your registration will be updated and it will show you the latest which you have done with the microscope. But one drawback, I wouldn't say drawback, it's a still, it will come up. So with microscope, you do an X and Y correction. Now, if you want to do a depth correction, so microscope is a wonderful tool. So adding microscope to navigation means microscope's focus will act as a pointer. Like what sir has asked, if I want to see the images on the ocular, how will I see? What I do, we calibrate the suction or any tool, and then because suction will always be in, so then we get an idea on what is going on in microscope. But then you'll have to keep an eye away from microscope. But the idea behind integrating the microscope is heads-up display, which will come to your ocular, and the focus of microscope, that focus will act as a pointer tip. You don't have to bring the pointer in or the suction to see where exactly you are focusing.
But yes, if you want to actually see, then you can bring in the pointer or the suction. You can calibrate third-party instruments, be it a suction or any rigid instruments, and then you can use it. It will act as a pointer. So with the microscope, you do X and Y correction, but for depth, you have to do with, if you want to, with every depth you have to do. So it's, I mean, it's a process that will, won't be, it's time consuming. So that's why we move to the advanced, which is the ultrasound integration or navigation. So therein you do a depth calibration, because we do the integration of different probes. There are 3 probes which are currently available with BK 5000. One is craniotomy, burr hole, and the hockey stick. So they are coming up with the one more probe. That I think endoscopic probe, something is there, sir. So that also we are in the process of integrating. So the idea behind this is you get a depth correction. So with every depth, you calibrate the probes, and when you acquire the scan, so that because it's a digital integration, and that too of a 3D ultrasound, so the image quality is as good as, you cannot compare with IMRI. I mean, MRI images, obviously, but yes, it will be good for you to check the extent of resection. This is like reading yeah. Yes. So yeah, it does not have any effect on this. So the effect that will have is the distortions, because the more sensitive or the more Tesla you increase of the CT, that's why we have something which is called distortion correction, which is specifically for MRI which is above 1.5 Tesla. So be it 3 Tesla, because we have developed so this was the manual segmentation. So we have developed a automatic segmentation. That is the basis of 70. We have a patented model, synthetic tissue model, which is developed basis the 7 Tesla scan. So there is no limitation. You can have 3 Tesla, 7 Tesla MRI. The only thing is it will add up to the distortions, which you will have to compensate, because the more, it's the common concept. If the more sensitivity will increase, then it will pick up small distortions also. So that is why you need a distortion correction, and especially when we are doing DTI sequences. So because those DTI are done at a 2 mm or 3 mm slice thickness. This is their basic property. So if I merge a 1 mm slice cut with a 2 mm or 3 mm, so this has 192 slices. This has just 70 slices. So it will definitely give me some error. So I have some examples of it. So when we actually compare it, so there are differences in the fusion. So, but we can compensate for this with the distortion correction. Yeah. Yes. Yeah. So we can integrate their data also. We have done it in Medanta. So I have some data in my laptop also where we have integrated their Connectomics data. Yeah, we could have shown, but there was so much of information flowing. So I still have that data. So we did one demo with Dr. Aliasgar Moidi only came. So because we can fuse any data. So once we take their Connectomics data, we can fuse it, and those parcellations will be visible in your data. Yes. In IBS hospital, I forgot the name of the surgeon, but we have shown there also with the Magic Leap and all those, because they are using this thing. So Connectomics. So I was at the manual marking. Then you have the automatic segmentation. So we have 190 structures that we can segment of the whole body. So once you click on the add anatomy, you have a list that will populate, and with one click, you can segment all those structures. So you see, these are all the list of structures depending upon the scan. So you can segment it. So segmentation means you just, suppose I click this, the software will do and it will ask you to verify. Yeah. Yes, yes, sure, sir. So once you have done the segmentation, all the structures are available to you, and on the viewer, it will be available as a, so I can show how it looks in the viewer, and then we'll go to this. Yes. So the good idea with exoscope is there is a limitation with microscope. That's why the yes. Yeah, because your line of sight that yes. So when it is with exoscope, you don't have that line of issue problem, right? But there is no working distance. Yes, yes. Now you are asking like how exoscope will over the virtual. So this is how the virtual will look, sir. But if I take the exoscope's output, you want on the 3D glasses, right? So it can come, but it has to first come to the navigation. So here the video will come, and then this can be just like that. This is all the technical technicals. So you can basically go inside or walk inside once you have the glasses. So these glasses have dual purpose. One is teaching patient, or other is the teaching students your the anatomy and all those things, and then patient counseling as well. So if two people are wearing the glasses, they can actually do the planning or do the consultation approach planning, how they will go for the resection of the tumor, or what's the best approach, because that's what I mean, I think Dr. Charlie also mentioned, like you need to have the right trajectory. So for that, you need to see the data in 3D, so that you can actually see where from where I should go. So this gives you that freedom. So you can rotate it, you can zoom in, you can walk inside the structure once you are so, and that can be projected also. So it has a streaming capability. So now this version of this virtual glasses is limited to pre-op, not intra-op. The other version that has released, that is used in intra-op. So that is already started in 2 of the hospitals. So they have done the surgery, the spine surgery. So first they have launched with the spine. So so everything, all the instruments will be tracked, and it will come like, this is your pointer, this is your chisel, everything will be tracked. And if you want to just with one button, you can switch off the augmentation, and you'll come to the virtual, the actual. Thank you.
Ugay, are you there?
Hello, everyone. I have some patient data here onto my planning system. And once I have the patient data here, I can also scan the QR code which gets generated. And then basis that, the entire plan gets populated in air in front of me. I'm wearing these 3D glasses right now. So I'll just stream it on the bigger screen so that everyone can visualize as to what I'm seeing. Okay, so now entire 3D and the entire plan has been transferred to the glasses. And what I can see now is the 2D image here on the right side. the black colored screen that would be visible. I can even scroll these images, and I also have the 3D rendering and the reconstruction here in front of me. I can even make it as big as the size of this hall. I can move the entire structure in any direction. So whatever structures I have planned in my pre-op plan are also visible here. I can actually walk inside the brain as well. So if you want to visualize it as to how it looks from inside, the moment I'm getting closer to it, now indicatively I have marked this section as a tumor, and now I am actually inside the brain. I can visualize it from multiple angle and orientation. And even to an extent, I can peel it further, layer by layer. Just assume if in case we are talking about a case wherein nidus has to be defined. So it's going to give me a very, very clear images in 4K as to what could be my area of interest, and then I can plan it accordingly, that how I should approach this. In case it's a tumor resection, I can accordingly look at as to what kind of a trajectory would be more apt and appropriate. I can give a brief demonstration and guidelines to the team. You can also use it in your tumor board meetings. It can also be a strong tool while you are doing patient education programs. You can orient and visualize it from multiple angles and orientations. And then whatever plans that you have made, that can also be transferred thereafter to the navigation system, so as to help you with the exact same delivery. And then you'll be able to have patient registered onto the navigation system, and you'll be able to deliver the same plan that you have created and visualized here. So let's assume that there were certain trajectories also that were planned. They would also appear here. If you're talking about a functional procedure, and let's assume if you would have planned some leads, multiple number of leads, they would also appear here in turn. And then thereafter, while you are delivering it actually onto a navigation system, you'll be able to correlate both the things. You can view it from multiple angle and also rotate it. Yeah, so in case there are some participants who want to have a look at it from the glasses. Yeah, there are some, please. Can you see it in 3D? Okay. You'll have to hold the controller here. Is there a laser which is pointed? So onto the laser, please don't press any button. Leave it free. Okay, this is zoom in, zoom out, zoom in, zoom out. And now you are moving layer by layer. In case you want to go back to the respective sections, it's like this. Yeah. Okay. So लेजर नीचे एक लेजर ये इससे प्रेस करेंगे इसके अलावा ये जी
Hey, Uday.
Yeah, we can conclude. I think we should close now. So good, nice.
Somebody has a question also.
Yeah, just hold on a minute. Wait, just hold on a minute.
Yeah, Mr. Bennett, you can conclude. Thank you. It was a wonderful session. So, Dr. A.K. Singh, sir, thank you for joining. Dr. Vinod, sir, thank you for joining. I think Dr. Charlie has left. Thank you. And it was a wonderful seminar to brief us, and it was a wonderful conference. We could link to the all people around the globe. Thanks to Brainlab. Thanks to all the senior faculty for briefing us how to move forwards. And it was a wonderful session. And thank you to all the seniors for last 40, 50 years. Mr. Bennett, thank you, and you can conclude now.
Yes, yeah, thanks everyone involved, especially Uday. And this conference was interesting to me in a few levels. One is the getting to know products. I think nowadays it's more important than ever for neurosurgeons to learn about the product. I mean, there's going to be a lot of new education with a lot of neurosurgeons that haven't done things a certain way, and they need interaction with people like Denton to learn what a Brainlab has, what kind of technology it is, what are its limits, where can it go. No longer, I think the die is set. There's going to be less and less conferences, in-person conferences, and there's going to be more Zoom. And I think this platform of Zoom allows neurosurgeons to get to know the tools better. So on that level, and also one thing before, this is a great conference, Uday, because there was a lot of interaction, and that was so good to see. That was so good to see that it's not just one lecture for a half hour or whatever, but there was a lot of interaction, and you helped foment that. You helped create that, and thank you.
Yeah, thank you. Another point of the conference was we held this conference in a very eco-friendly mode. We haven't printed any single paper, printed a single paper, and everything has been carried out digitally. And there was no money also raised up. So we cared on a very eco-friendly mode also. That has to be brought to the world notice. We care for Mother Earth also. Thank you.
Thank you, Bennett. Once again, we had certain glitches which was managed somehow, and